Hi everyone, today we have a little bit of a different case for you. I know normally we've been doing a lot of breast cases, and what you see in front of you is a skin case, but even though this is technically bone soft tissue derm realm, this is also something that we tend to see in the breast. So what we are looking at here is essentially a baby angiosarcoma. And when I say essentially, this is angiosarcoma. So angiosarcoma is a rare condition in adults. It's extremely rare in children and young adults, okay? So you want to think older adults. And when we're thinking breast, we're thinking older women. So they tend to be 60 to 80 years old. And the risk factors that are associated for developing angiosarcoma generally are chronic lymphedema, radiation, so that's where our breast is coming in with that radiation to the breast wall or axilla, as well as sun exposure, and then there's some chemical exposures, whether it's PVC or thorotrust. Okay, I'm going to show you a little bit of the histology here. So yeah, maybe a little better at 4x, maybe. So like I said, we have some normal skin. We can see that there's some chronic inflammation. Anyone who's a derm path is probably cringing at my description. But what we see in our superficial dermis here is that there's a lot of these slit-like spaces, these sort of weird-looking vascular type channels, okay? Now, grossly, how will you see these lesions? How will the clinicians look at this and go, I'm really concerned about this. Is this a dermatitis? Is this like some sort of bite? Or is this actually angiosarc? And the description that you'll get from the clinicians will actually vary depending on the clinical history. So if the patient has a history of this long-standing chronic edema, well, that tends to be lymphedema in the extremities. So that's where you're more likely to see the lesions. If they don't have lymphedema and no history of exposure or radiation therapy, these tend to occur on the scalp or face. And this is actually from the scalp, but you can see these anywhere, okay? Angiosarcs also love to involve soft tissue. So this is where I was saying this is bone soft tissue derm realm, because they do tend to occur in the bone, in the breast as we've already discussed, as well as heart, lung, liver, spleen, thyroid. So you start to see the picture, how you really need to be able to recognize these patterns really anywhere you go. And if this is a very new lesion or an early lesion, what the clinician might describe is there may be one or multiple small well circumscribed, well defined nodules, okay? And like I said, there can be single or there can be multiple. And then as the lesion progresses, it's been there a while, they tend to be more fleshy or that grayish white sort of fish flesh type appearance. And that's when you can really start seeing that there's hemorrhage, maybe there's necrosis, and that's also when you'll start seeing that there's actual invasion. Okay, and that is one of the ways that you help differentiate from some other lesions, okay? But anyway, back to the micro. So we said that we have all these weird looking vascular channels, and they can be dilated more often. I've seen them, they're slit-like, and they are lined by these really atypical endothelial cells. In this case, it's like a single layer of these really hyperchromatic endothelial cells. But sometimes what you can actually get is multi-layering or papillary tufting or even hobnailing. And hobnailing is when the nucleus is kind of jumping up off the base of the cell and it's protruding into the lumen, okay? So that's what hobnailing is. And we don't really have that here. We just kind of have these atypical endothelial cells. And why are they atypical? Well, they're hyperchromatic. We all know that endothelial cells can scare you because when they're reactive, they can show all these different shapes. But again, it's like as we move around here, never a good idea for me to try to move when when I'm on high power, since it just kind of puts everything in focus and maybe shows I have a bit of a palsy going on. But this is a good view. Okay, so let's just kind of put that back front and center. So what we see here is that we have these vascular channels. Oh, get in focus. There we go. Okay, and the nuclei are very irregular. Some of them are extremely hyperchromatic. And this is kind of what you're looking for. Obviously, with more pronounced lesions, these can actually even become more solid in appearance, and in those instances you can have like wild pleomorphism. Okay, so just because you're seeing minimal versus wild pleomorphism, that can still be within the angiosarc. Okay, they have variable grades, and that's what they're talking about when they're saying variable grades in angiosarc. However, if this was a breast skin, let's say, for example, since I'm crazy about breast path, radiation patients, after they've had radiation, if they develop angiosarc, it tends to be high grade, so you would expect wild pleomorphism. You can see multinucleated giant cells, okay, and you also can see once in a while maybe even hyaline globules, which we don't really have here. Maybe one or two going on there. And what you see when you have these hyaline globules is that those are actually either your alpha-1 antitrypsin or your alpha-1 anti-chymotrypsin. Okay, so if you see those, remember we can see angiosarcs in a wide variety of organs, so don't let that scare you. And as we can tell here, it's often affecting your subcutaneous tissue, and these lesions can go very deep. The margins tend to be very infiltrative, so they can be very difficult to get around. Something else that you can keep in mind is that angiosarcs, definitely in the breast, can be associated with these blood lakes. And what a blood lake is it's like massive amounts of extravasated red blood cells that are in the tissue. So these will look very hemorrhagic. You could even be thinking that, okay, is this maybe like some really weird like lobular capillary hemangioma, or what used to be known as pyogenic granuloma, which is great because that's actually in your differential. But again, you'll have that atypia within these endothelial cells, okay? I realize I'm kind of just on the same spot, but it kind of just looks similar everywhere we go. So here again, we can see that there's some atypical cells in these slit-like spaces, and there's just too many of them going on. Again, so the solid areas, if present, so I suppose I should have reiterated that, is that when you have the blood lakes, is that tends to be in the solid areas of angiosarc. So if you're just seeing like these slit-like spaces, I wouldn't necessarily expect to have the blood lakes, but if you have really high-grade lesions, they're developing more solid nodules, that's where you're going to see that. These are sarcomas, so do expect to see mitotic figures, and you can see a lot of necrosis with these as well. Not really appreciable on this, but this is a small biopsy, and as I maybe not so aptly termed it, this is like a baby angiosarc, okay? So this actually was caught relatively early. As far as your markers, I do have a few of those to show you. So this is a vascular tumor, right? So we would expect our vascular markers to be positive. So the first one I'm going to show you, and we'll go over all the markers that you can see. But this first one, as we go over to our control, which is great. Oh, there we go. Because I did know that there was positive control on here. Okay. All right. So, not a lot of staining, but this is your CD31, okay? And I know there's more. So you start seeing more of them. Maybe a little more appreciable. No one's thinking I'm just blowing smoke. Okay, so this is what your CD31 should look like. Now if we go over to our lesion, look at that. I'd say that's a bit more, and then this was in the area that we were looking at. So if we go up to 10x, you can see how it's highlighting all those slit-like spaces. A lot of those atypical cells, I mean, look at that guy. Woo! So this is CD31. Okay, so CD31 can be positive. Something else that you might think of with vascular markers, and it has a very similar control, is CD34. Okay, now CD34 likes to stain a lot of things, right? But we tend to still think of it as, well, we can use it for vascular. Yeah, helps if I go in the right direction. Okay, so here's our biopsy again. And we can see, well, it's not really helping us, right? Like the normal vessels are being stained, and there's some funny background type staining, and maybe we got some stuff going on here. But a lot of these, so like that really dark area that's sort of in the center, that's just like really weird staining. But so CD34 you can see, you don't have to see it. And the other stain I have to show you, which is a really nice one we don't see too often. This is ERG, E-R-G, ERG. So we can see nice, clear, crisp. Okay, so that's our control. And if we go across to our tissue again, find the tissue on the slide, hard one, it's a little biopsy. Isn't that just gorgeous in a totally terrifying way? So we can see that stuff that maybe was a little harder to appreciate on H&E, and we'll go back to the H&E so that you guys can see if you can find these cells. But you see how all these atypical cells, like these don't look like they're forming regular vessels, right? And we go up to the skin, and we see again those atypical cells are being highlighted. And there should be another piece. Oh, there we go. Another piece. So okay, there's no mistaking that ERG is positive in these lesions, in this lesion. But look how it just brings out these really bizarre shaped cells. They're different sizes as well, not just shapes. And so these are some of the things that you can see. Okay, let's go back to our H&E. And we have to get back in focus since our IHCs are a little different. Okay, and even at 4x, you can maybe start to appreciate that we have some atypical looking cells. Their size is a little off. Look at how hyperchromatic they are. They just don't really seem to be in the right place at the right time. If we go up to 20x, okay, maybe 20x isn't helping us too much. Kind of just looks like everything just looks atypical at this point, right? Okay, so if we go back to go back to 10x, you can again start to appreciate that, hey, there's some extravasated red blood cells. These cells are just a little too atypical. And look at that guy hanging out there. That's crazy. Other stains that you could use factor 8. We talked about CD31, CD34, ERG. You could use FLI1, FLI1, which should be nuclear in angiosarc. You can also use thrombomodulin. Your keratins might be positive. It's kind of variable. I wouldn't hinge on keratins, but if it looked epithelioid, you could do that. And you can also see c-KIT or CD117 positivity in these lesions sometimes. And one of the interesting stains that you could try is VEGFR3, and that's variable, and it has to do with the moleculars. So about half of these cases are going to have MYC amplifications, MYC amplifications, and that's located on chromosome 8, Q21, okay? And MYC, as you know, is a proto-oncogene. The thing that I was talking about with VEGFR3 is that when you have a FLIP4 mutation, you actually can get a VEGFR3 amplification, and that's located on chromosome 5, Q35.3, and that occurs in about a quarter of cases with secondary angiosarc. Oh, I apologize. I should have said that the 50% that have the MYC proto-oncogene amplification, that's half cases of secondary angiosarc. And what's the difference between secondary and primary? Well, Primary means it's idiopathic, so there was nothing before that, it just happened out of the blue. Secondary means that you induce that, and most often that's induced by treatment, so that's the patients who have had radiation, okay, or they've had like the PVC, thorotrast exposure, those kinds of things. So it's secondary. There's something else that happened and that created the perfect condition for angiosarc, okay? Differentials, we've talked about a couple of these already. So it could, well, if it's just an atypical vascular lesion, well, atypical vascular lesions shouldn't have as much atypia, and they shouldn't have the increased mitotic activity, okay, as a minimum. You could also think, well, if this is just florid vascular proliferation, well, those tend to occur in the colon, and they tend to be associated with intussusception. Okay, so if this is on the skin, that's obviously not in the colon, so you need to really associate your clinical history with whatever's going on. A good thing to think about is what if this is just a hemangioma. Well, hemangiomas tend to have very thick vessels, not these thin-walled, slit-like spaces, and they tend to have fibrous septa. We don't see any of that here, so we can rule that out, okay? And one of the more tricky things, I think, to rule out would be an undifferentiated high-grade pleomorphic sarcoma, and that's also known as malignant fibrohistiocytoma, okay? Those have variable CD31, whereas we saw that the CD31 worked really well on this, and they also tend to have what's called intratumoral macrophages, and what that means is that you have macrophages all over inside the tumor, okay? Treatment for these, for the most part, they're going to try and surgically excise them, as I give you guys a headache going around it. But you just see, like, as we're zooming around on 4X, those atypical cells just really become more and more pronounced the longer you stare at them. And I'm hoping you're appreciating that, and if you aren't, please let me know in the video, because maybe we need to focus on those kind of things more, because you don't do everything in life at high power, so you want to be able to see these things at low power too. Okay, so for treatment, yes, they're going to go in surgically excise. Very difficult to do because you can't see the margins. The margins are infiltrative. What if it's just blood related to the procedure, or what if it's a blood leg related to the angiosarc? So many things, and these can be very difficult to clear, or they may be impossible to clear if they don't have enough tissue to close, or even with a wound vac, or if they're looking at doing flaps. This might not be something that they can clear. Okay, so keep that in mind, that is a real possibility. There's not a lot of good data for doing chemo and radiation, at least not in the breast world, and that's where I know more things about. They may still do them, but the data really isn't there, so it's not really proven one way or the other what helps, what doesn't help. And going back to that FLT4 mutation, if that's there, there's potential for using something like a TKI or tyrosine kinase inhibitor. But as far as I know, those are still in studies, okay? And a lot of the clinical studies right now are unfortunately on hold, secondary to COVID-19 restrictions. But that is also something to consider. Prognosis for these, if they don't have any metastasis, the 5-year survival is about 35%. So not great, even without metastasis. If they do metastasize, they go to the lymph nodes about 15% of cases. So of metastasis, about 15% of those will have lymph node mets. Now, 15% to lymph nodes, that doesn't sound very high. However, for a sarcoma, that's extremely high, okay? So that's something you want to keep in mind. It may be just a correlation between, well, we have like a vessel-related tumor and going to the lymph nodes, maybe bridging that way. However helps you remember, just try to remember that. Other places it can metastasize, not too surprisingly, would be lung, liver, and bone. But really think about those lymph node mets. And again, these are rare tumors. Rare in general, extremely rare in the breast. Again, this is a scalp lesion, so that doesn't necessarily apply, but just something for you guys to keep in mind, okay? And that's what we have for today. So this is our review for the week of May 18th, 2020. And I also want to let you know that on May 25th, that is a holiday, so there will not be a short review that week, but we'll be back from holiday by then, well, holiday staycation at this point, and we'll have a lot of new material for you guys, okay? If you like this video, please hit like. If you aren't subscribed to us already, hit subscribe. If you have anything to mention, things I forgot, things I missed, if you have interesting tidbits about angiosarcoma anywhere else in the body, I'd be happy to see those in comments. If you have things that you'd like us to go over at some point in a future short review, please let me know in the comments. You can follow me on Twitter at Cairo Slide Review, and also send me questions, interesting cases there, because I love seeing that, and I love seeing how interested a lot of you are in learning different pathologies. And that's all we have. So thanks for sticking around, and stay safe.